You're listening to This Week in Cardiology from theheart.org on Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or, Alexa, what's my flash briefing? I hope you'll join us.
Hi everyone, this is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for August 13th, 2021. This week, COVID, vaccine-induced myocarditis, Watchmen complications, SGLT2 inhibition, and cardiogenic shock. The COVID situation is really unchanged from last week. The cases due to Delta continue to rise, and hotspots such as Florida and Texas and Louisiana seem to be driving it. I live here in Kentucky in the southeast, and I've been following our situation closely. Early this month, we went from one COVID ICU patient to 11 in like 3 days. It was a shocker. But all week, in the last 10 days really, we've stayed steady at around 8 to 9 ICU patients. Like everywhere else, nearly all hospitalized patients with COVID have risk factors and are unvaccinated. And adding to the stress in our city, and maybe yours too, is that even before this uptick of COVID admissions, all of our hospitals were working at capacity with non-COVID related disease. So even this modest increase in admissions has stressed the system. We've had local news here report that all hospitals in our area have many unfilled staff positions. Some of our statewide bed crunch is certainly due to these staffing challenges. I would not want to be a hospital administrator these days. I saw a report that a medium-sized hospital in rural Kentucky, which already had staffing shortages, had a number of staff quit because of the vaccine mandates. I am pro-vaccine. I encourage my patients to take it. The harm-benefit calculus in adults clearly favors vaccination. The main issue, of course, is how to get more people to take the vaccine. And gosh, it is just so sad to walk through our ICU and see the unnecessary suffering. The main thing I think about every week when I write this section of the podcast out is how could we have done better with vaccine acceptance? What are the lessons to learn about public health messaging? All right, next topic, COVID vaccine myocarditis. Now, you may think it's strange that myocarditis keeps making the podcast, but it's not me. JAMA Cardiology has published another study, a case series of 15 children hospitalized with myocarditis after the messenger RNA vaccine. The lead author of this report was Audrey Dion, and co-authors were from Boston Children's. The kids ranged from age 12 to 18. The median was 15 years. 14 of the kids were male, 1 female. The symptoms began about 3 days post-vaccine, and all patients had chest pain as an early symptom. All of these patients had elevated troponins, and at the time of discharge, all of the patients still had elevated troponins. By echo, 3 of the 15 had LV global hypokinesis. By CMR, 3 patients had LV dysfunction, and findings were consistent with myocarditis were seen in 13 of 15. 13 of 15, LGE, late gadolinium enhancement, was noted in 12. Now the follow-up at 1 to 2 weeks post-discharge. 4 of the 15 were asymptomatic and had normalized their troponin and ECG. 4 of the 15 had persistent symptoms. 1 still had mild LV dysfunction. 1 had a recurrence of non-sustained VT at follow-up, and 3 had persistently high troponin levels. I will separate the author's discussion into the good news and the bad. The good news is that no kid required ICU, and all were discharged alive within 5 days. Left ventricular function mostly improved to normal, and only 1 kid had VT. Now, I know you may be wondering about calling that good news, but this is the COVID era. Now for the not-so-good news. And notice the euphemisms and jargon. I'm going to quote, CMR-LGE was a frequent finding at the time of diagnosis. In this clinical setting, LGE reflects an increased volume of distribution of the gadolinium-based contrast agent in the affected region, likely related to myocyte necrosis, and/or extracellular edema. Quote, in non-vaccine associated myocarditis, the presence of LGE is associated with an increased risk for adverse cardiovascular events during follow-up, end quote. Now, myocyte necrosis means cardiac cell death replaced by scar. Much of what I deal with in the EP lab is scar-related arrhythmia. Now, I want to be clear, CMR scans can definitely improve and normalize, but I agree with the authors the long-term prognosis of these kids remains unknown, and I intensely want to push back on the characterization of any of this as mild, which I have seen in many media reports. A sore arm is a mild adverse effect from a vaccine. Cardiac injury due to inflammation, enough to warrant hospitalization and cause scar formation in the heart of previously healthy kids, is not mild. Even in the short run, these kids will be told not to exercise or participate in sports for many weeks to months. Their parents will worry. Calling this stuff mild crushes public trust. I think the better messaging is that this is a quite serious, but fortunately rare, adverse effect. I'm currently writing an academic paper that's under review on this topic, and I can't say much about it, but I will say that the harm-benefit calculus of the two-shot messenger RNA vaccination in healthy young adolescent males is immensely different from a 50-year-old person with obesity and hypertension. The take-home of the vaccine myocarditis trade-off is not binary yes or no vaccinate adolescents. It is, should we study one shot in this group? Should we consider different formulations of the vaccine? Should we wait a bit and see what happens in the 4 to 6 weeks once Delta passes through? Will the Novavax be a better choice? All of these questions, I think, are reasonable questions. A mom of a 16-year-old star athlete asked me about this week. She had read the CDC data, and she was concerned about both COVID as a disease and vaccine-induced myocarditis. Next topic is Watchmen. Now, I know you are thinking, come on, Mandrola, give us something different than myocarditis and Watchmen. But again, JAMA Cardiology has published a very important paper on left atrial appendage occlusion with Watchmen from the NCDR registry. The NCDR registry was mandated for Medicare patients, so right off the bat, it's going to be a far better data than the voluntary registries in which patients are enrolled at the discretion of the clinician. Always look at that, friends, whether a registry is mandated or voluntary. Okay, remember Dr. Joseph Bavaria's comments. Science tells us what we can do, trials tell us what we should do, and registries tell us what we are actually doing. The purpose of this study was to report on sex differences and major complications from the Watchmen procedure. The study group was nearly 50,000 patients implanted between 2016 and mid-2019. The median age was about 76 in both men and women. Now, surprising to me was that 41% of the 50,000 were women. The CHA2DS2-VASc score was a bit higher in women, 5.3 versus 4.5. The Hasbled score of both groups was around 3. And here are the results, the in-hospital complications. And again, remember, this is real-world data from a mandated registry for Medicare patients. Any adverse event from the procedure, 6.3% in females versus 3.9% in males. Any major adverse event, 4.1% females versus 2.0% males. Hospital stay greater than 1 day, 16% female, 11.6% males. You might wonder what the major adverse events included. These were indeed major, things like death, cardiac arrest, stroke, hemorrhagic stroke, major bleeding, major vascular complications, heart attack, pericardial effusion requiring drainage, and device embolization, which is a euphemism for the device went missing. After adjustment, women compared to men were 64% more likely to have any adverse event, twofold more likely to have a major adverse event, and 46% more likely to require hospitalization longer than 1 day. So my comments. Here is yet another sobering report on this preventive procedure, Remember, friends, left atrial appendage percutaneous closure is supposed to prevent something that is yet to happen. Let's make a hypothetical here, for the sake of an argument. Let's forget the fact that the first trial, Protect AF, did not pass FDA muster. Let's also forget that the second trial, Watchmen versus warfarin, Prevail. This trial missed non-inferiority in its first co-primary endpoint of stroke, systemic embolism, and CV death, and that was because of a doubling of the risk of ischemic stroke in the Watchmen arm. Let's also forget that the major bleeding rates were similar in both the warfarin and Watchmen arms. And let's spot the proponents of Watchmen that there is a 1 to 2% net benefit in the future. There likely isn't, but let's just say there is. Let's just say there is. This data reports that a typical female Watchmen patient starts the future probabilistic gamble with a 6% chance of any adverse event and a 4% risk of any major adverse event during the hospital stay. This doesn't even count the patients who come back with a bleed or late tamponade or device thrombus or stroke after a day or week or month. These are just in-hospital complications. Now, men fare a little bit better, but even they have a 4% risk of a major adverse event. So even if you bury your head in the sand and ignore the regulatory trials and you take a rosy view of future benefit of this procedure, every patient starts with a very significant risk of harm. Now, proponents might say that women do worse because of case selection. If docs were only a little smarter, it would not be like this. But of course, I would counter that logic by saying that the registries tell us what we are doing. This paper is a good use of registry data, and it provides very useful data to patients considering this preventive strategy. It is what it is. Now, proponents might say that most of the included cases were done at low-volume centers. Here at our big shot referral center XYZ, we don't have complications. Well, I would counter that by saying that not only did the regulatory trials and registries average out to a 6% complication rate, I can cite at least 2 real-world registry studies with similar or higher complication rates. And here's another worrisome thing. Complication rates from this procedure seem to be skyrocketing. I went back and looked at some other papers from the NCDR registry. In 2020, last year, a paper from Freeman et al. And Jack, and I'll link to it, they looked at NCDR registry data and reported a major adverse event rate of 1.9%. Now, this included 663 complications in about 38,000 procedures. The new paper from the NCDR registry, this included 11,000 more procedures and 6 more months of data. And they reported a combined complication rate, if you add males and females, of 2.8%. That's 1,394 complications in about 48,000 patients. So that's 731 more complications in just 11,000 more procedures. So in the last 6 months, it looks like there's a 6.5% rate of major complications. Now, I've sent an email to the authors to comment on this huge rise in complications, but just going by the absolute numbers in the last paper, at minimum, it's a nearly 3% rate of complications if you take the total between males and females. That's a big headwind for any patient. And finally, 97 patients in this last study died in the hospital after this procedure. Nearly 100 humans died for a procedure without any proven benefits. My friends, I think this is a huge blind spot in cardiology. Now, a couple quick short stories before I close. On dapagliflozin, the European Union announced that it has approved dapagliflozin to treat patients with chronic kidney disease who do not have diabetes, just CKD. This is based on the results of the DAPA-CKD trial, which randomized about 4,300 patients who had a GFR of 25 to 75 and an abnormal urinary albumin to creatinine ratio to either DAPA or placebo. The primary endpoint was a combined renal and CV composite, and it was reduced by about 39%. And additionally, there was a 29% reduction in CV death or heart failure hospitalizations and a 30% reduction in all-cause death. Now, at least once a week, I'm sending notes out to referring docs asking them to start an SGLT2 inhibitor. But of course, the biggest headwind for these drugs in the U.S. is cost. Recently, a patient sent me a note saying it was going to be $500 for a 90-day supply of DAPA. That was just simply impossible for this patient. This class of drugs just continues to impress me. These drugs are long past being thought of as a diabetic drug. Now, renal preservation, heart failure with reduced ejection fraction. In a couple of weeks, we will hear at the European Society of Cardiology meeting how much they improve outcomes in heart failure with preserved EF. That's right, a successful drug for HFpEF. Final topic today is on cardiogenic shock. Now, I don't know about how it is at your place, but at mine, people look at me like a relic when I ask, what about good old dobutamine in this patient with low cardiac output and cardiogenic shock? They're like, come on, Mandrola, everyone knows Milrinone is better, especially in patients with pulmonary hypertension. Now, of course, recall that these drugs differ in mechanism of action. Milrinone is a phosphodiesterase 3 inhibitor. It increases cardiac inotropy. It improves cardiac relaxation and peripheral vasodilatation. Dobutamine is a synthetic catecholamine and it acts as a beta receptor agonist and improves blood pressure by kicking the heart and increasing cardiac output. Well, New England Journal of Medicine published this week the Do-Re-Mi trial, which found absolutely no difference between Milrinone and dobutamine. The trial with the unforgettable acronym Do-Re-Mi was carried out at the University of Ottawa. First author, Dr. Rebecca Matthew. This was 192 patients that were randomized to either Milrinone or dobutamine. The primary endpoint was a composite of death, cardiac arrest, transplant or mechanical circulatory support, MI, stroke, or dialysis. The mean age of the patients was about 69. 1/3 of them were women. The median EF was 25% and 2/3 were ischemic, 1/3 non-ischemic. Pulmonary artery catheters were used in less than a quarter of the patients. Now the results. The primary outcome occurred in 49% of patients in the Milrinone group, 54% in the dobutamine arm. The hazard ratio was 0.90 and the confidence intervals went from 0.69 to 1.19. The p-value was 0.47, not even close to significant. All of the secondary outcomes, death, cardiac arrest, transplant, mechanical circulatory support, stroke, dialysis, did not differ. ICU length of stay, not different. Normalization of lactate, not different. And arrhythmias, right? Dobutamine supposed to be worse? No difference. Now my comments. This is a pragmatic trial, and we need more of them. And kudos to the group at the University of Ottawa. And once again, the story is quite similar, isn't it? Milrinone had become the agent of choice based on plausibility, it should work, right? Weak observational studies, and one RCT of just 36 patients. Yet the Do-Re-Mi trial found no differences in any major clinical outcome. And with a p-value of 0.47, you can say if there were no differences in the two drugs, the chance of seeing this data or something more extreme is basically a coin flip, not strong data. But my friends, there is a major caveat here. The biggest issue, and the reason I would hedge, is that this trial was powered to detect a large 20% absolute reduction in the primary endpoint with Milrinone. 20%! Now remember, to detect large effect sizes, you don't need as many patients, and therefore the cost and burden of the trial is lower. That's good for the investigators. The problem, of course, is that if you underestimate the effect size and you recruit fewer patients, you could end up with wider confidence intervals and the possibility of not detecting a smaller but still clinically important difference. For instance, in this trial, the confidence interval of the hazard ratio of the primary endpoint went from 0.69 to 1.19. That means Milrinone may have been 31% better or 19% worse than dobutamine. And when that happens, we say that the trial was underpowered. If you think about it in Bayesian terms, the strength of the data in this trial doesn't do much to change your prior. It's like a medical test that is equivocal. If you were skeptical that Milrinone was better than dobutamine, you would stay skeptical of Milrinone. You would say this trial makes it unlikely that there's a large benefit from Milrinone. If you were enthusiastic about Milrinone, you could make an argument that the lower bound of the hazard ratio went to 0.69, and a bigger trial may have shown a difference. Now, my take would be that dobutamine is a less costly drug. Given these results, in patients like those in the trial, it makes sense to choose the less expensive drug. Or at least, at minimum, we ought to change the prevailing prior dogma that Milrinone is the obvious best choice. Now, finally, we don't even know whether inotropes do anything versus placebo in cardiogenic shock to begin with, and the investigators will plan a follow-up Do-Re-Mi 2 trial looking at inotropes with a placebo arm, and I think that's a smart thing to do. One quick note before I close. The New England Journal of Medicine has published 2 trials looking at anticoagulation in hospitalized COVID-19 patients, and they're very complicated trials. They use Bayesian statistics to interpret the data, and next week I'll have a full report on those, and I'm happy because I can talk about Bayesian statistics because that's actually what was used. So that's it for this week in cardiology. As always, friends, I'm grateful that you listened. Thank you. And remember, if you like this podcast, please take the time to give us a rating, write us a 1 or 2 sentence review. These things go a long way to help others find us. Until next week, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org on Medscape.